We got this very young man, 21 years old, and he came to us with a complaint of proptosis, swelling of the eye and redness of the eye on the right side. And he has a history of fall. That is about 1 month back with some head injury. He recovered well from the head injury, and now it is about a month time, and he came to us with proptosis and congestion, double vision in the right eye. So we examined the patient and did CT scan and MRI, and we found that the patient is suffering from a Caroticocavernous fistula. We have taken for an angiogram for this patient, digital subfraction angiogram. This is a right carotid artery angiogram, which is showing that the right carotid artery is opening into the cavernous sinus, and there is a huge reflux, especially into the supraophthalmic vein, and then into the jugular venous plexus, and there is hardly any cerebral circulation. So this is a 3D. And as we look at the 3D, we can understand that there is a very high flow fistula. This is the carotid artery which is opening into the cavernous sinus, raising the pressure of the cavernous sinus up, and the blood is going through from the cavernous sinus into the supraophthalmic vein. Hence the patient is not able to drain the venous drainage from the eye into the cavernous sinus. There is a reversal of flow. That's the reason the eye is congested, looking red, and there is a diplopia, and that's how the problem is. This is called a Caroticocavernous Fistula. And this is the AP view, again showing the same pictures of a Caroticocavernous Fistula, direct type A Caroticocavernous Fistula. This is important when we are doing the angiogram of the carotid artery on the left, and we see that through the anterior-communicating artery, the blood is coming down into the fistula, and the fistula is filling even from the left carotid injection. We have such patients, we should do a cross compression study, and this cross compression study is done with the compression on the same side of the fistula with the injection from the other carotid and vertebral artery, basically to look into the cross flow as well as the site of the fistula. Here we are trying to locate the site of the fistula. This is the lateral vertebral injection, which is showing us the site of the fistula. This is the vertebral artery injection through posterior communicating into the cavernous sinus, and because this is a very high flow fistula and the blood is getting sucked, so this is the site of the fistula. So now once we have decided the site of fistula and it looks like this, so there are multiple options for treatment. The first thing, we can go from the carotid and we can do a coil embolization. Second thing is we can go from this into the fistula and do a coil plus onyx injection. And then the third option will be going here and putting a detachable balloon and embolization. And the other option will be to just go across the fistula and put a stent graft, so the fistula is excluded from the circulation. And here we will go with the stent graft and try to place it from here to here. So once we put the stent graft here to here across the fistula, this fistula should not fill anymore. To treat this patient by putting stent graft across the fistula, we have taken the patient under general anesthesia and taken access into the right carotid artery, and we will put a 7F long sheath up to here, and then we will put a distal access catheter over here, and then we will go with a wire. And meanwhile, I'll take a roadmap through the vertebral artery injection and the fistula site, which will be demonstrated much better, and then I can place my stent precisely over the fistula. So to do that, first I'm going and doing a balloon occlusion test and a fistulogram with a balloon occlusion to be very precise about the site of the fistula. So now I have taken a 7F long sheath, and inside the 7F long sheath we have this distal access catheter which is going all the way to the site of the fistula, because we are going to take a graft master which is very stiff stent graft. So it's better that we should have our distal access catheter all the way near the fistula. This is a 6.3 French distal access catheter from Stryker, and this is how it looks like once we have put this. And this is just at the fistula, you can see that. And once I have done that, then I have taken this is my graft master pen graft, which is just across the fistula. As we can see, this is the site of the fistula, just at the center of the graft, and this is the center of the graft, and this is the site of the fistula. So look at the first frame to better know the site of fistula. This is the site of the fistula, and I might pull my graft master a little bit all the way till here, and then start deploying. So I just pulled my graft master a little bit and then start deploying over here, and this is the site of the fistula, and covering right from about 3 millimeter from here and about 3 millimeter from here. This is a 3.5 into 19 graft master, and nicely getting deployed over here. And once we have done that, so this is fully opened graft master over here. This is the fully opened graft master over here, and this is our angiogram after the graft master. We can see that the fistula has dramatically slowed down but still filling. So this can happen when you have your proximal or distal end of the graft is sitting on an angle over the internal carotid artery. Decided to take another, so this is another graft master over here. This is the graft master, the first, and this is the second, just getting inside it. So just a small apposition and then bring it back, because this bend is allowing the blood to sip between the vessel wall and the graft. So I've taken another graft and just deploying it from the proximal part of the graft master down. And once we have done that, this is check angio. It's looking beautiful. There is no sign of the fistula at all. It is completely gone. The right caroticocavernous fistula is completely cured. And this is my lateral view. And we have to take a common carotid injection to see whether sometime your external carotid might so better. So we have a beautiful length of carotid, and the grafts are sitting there nicely. We can see there that's a graft, and the fistula site is closed, and there is no caroticocavernous fistula filling whatsoever from the external or internal carotid artery. Angiogram showing there's a beautiful cure of this disease, the caroticocavernous fistula, which is a traumatic type A caroticocavernous fistula, which is now cured.